With me is Professor Rafael de Caterina from Chieti in Italy. I'm Paul Hugenholtz from Wageningen in the Netherlands, and we're going to talk a bit about the nutritional habits of today, the onset of coronary heart disease and atherosclerosis. And my first question to you, Rafaele, is do you believe in the Mediterranean diet? You have eaten it, I presume. The people around you have. What is today the status of that sort of food in Italy, and how is it in the rest of Europe, according to your assessment?
The idea of Mediterranean diets as being healthy, as you know, dates back to the studies of Ansel Keys in the 50s and the 60s.
The seven-country study.
The seven-country study. But this was the pointing out the elements of diets that existed in southern Italy, in Greece at that time, which is now probably profoundly changed nowadays. Actually, also the idea of one single Mediterranean diet probably is a simplification, because there are many types of Mediterranean diets around the Mediterranean Sea. But the basic concept that this is a poor diet, poor in calories, with little contribution from meat and beef, highly rich in vegetables, highly rich in olive oil, with wine, and with some introduction of fish that varies according to the region. This idea has been proven healthy in a number of epidemiological studies, including the seven-country study that opened the way of the idea, the concept of the Mediterranean diets, and then has been proven useful in intervention trials, the last of which has been the Predimed study run in Spain, in which over a controlled diet that also consisted of advice in reducing fats, saturated fats, Mediterranean diets produced a substantial decrease in morbidity and mortality.
That was published in the New England Journal of Medicine this year, and I'm sure we'll talk about it a little bit more, because some people doubt some of the methodology, and that's where I want to come back to. The methodology of such studies is not perfect if you believe the strict rules that are being applied to, shall we say, pharmacological agents. And I'd like you to say whether you think it is necessary, when we talk about foodstuffs, which are not necessarily toxic, which have no major side effects, which are not artificial, that we should apply the same rules as have to be applied to substances such as, shall we say, the statins. Because that confusion reigns, and when you just now said that the epidemiology is very convincing, I know of certain people who feel that it should be a randomized future blah 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 study. Unless that is done, we have no definite proof. Can you lay that to rest?
Very difficult to run a randomized placebo-controlled trial in the case of diet. Very difficult because you cannot really blind the diet. But in addition, there is one point that I like to make, is that diet is a combination of compounds, is never one single compound. And I think it's futile to look for one single magic compound that does the trick of a diet. It's always a combination of factors. And because of this, I think it's a dream to isolate one single compound that can produce the overall healthy benefits of a diet. And this means that we probably can apply the criteria of pharmacological medicine broadly to a diet overall, but it's hard and probably impossible to do it with single compounds isolated from the diet.
But you'd still take the position that wouldn't it be nice if it would be possible? I argue that we do not have to apply those rules that have to be applied to pharmacological agents. We can rely on epidemiological observations, even incidental observations. And I think this application of one rule is detrimental to thinking about good food. Let's not forget, Hippocrates said, let food be the medicine. And I think that applies today. But we should learn how to apply modern, shall we say, scientific methods and step away from this evidence-based and must have a hard endpoint of death and so forth when we talk about foodstuffs.
I agree. I broadly agree with this, and I stated also in other occasions that epidemiology is probably the best way to prove the efficacy. It's hard from epidemiology to derive a certain causality link, because you would always like to do it with the rigorous criteria that we have learned after Pasteur. But I think we have to live with the possibilities that we have. We cannot today, as to take your example, run a study on human milk to raise infants and randomize them to milk or no milk.
That's a hard endpoint.
Yes.
That would be ridiculous, but it is argued. Let's shift the topic slightly to the purpose of our meeting here and the ultimate goal of our video program. We will have some lectures, we will have some interviews, and I would like your opinion on how we could use the end product to influence and tell our colleagues where the situation is. Should we send the video disc around to the universities? Should we spread it from one to the other? There's so much confusion on the field of food and food substances and atherosclerosis that I hope this video program will help clarify it, but then we have to distribute it. How would you go about it?
I think this issue of spreading the information is extremely important, because there is a perception among the cardiological community that this is soft science, is less rigorous than pharmacological science. First of all, the interests that are at stake are much less than in the pharmaceutical world. So we have a problem perhaps of drifting scientific information according to the interests of companies, and the cardiologists probably should look at the overall evidence of benefits coming from possibilities of intervention with drugs, but also intervention with food. And I think realizing that prevention is a very important issue in general. In cardiovascular medicine is probably the way to go to reduce the burden of cardiovascular disease in the world, not only in Europe. I think the concept of diet as something that needs to be reinforced, something that needs to be also implemented with studies and with scientific attention, is of utmost importance.
I'm very pleased with your reply because, as you say, interest is in technology, interest is in pharmacology. I saw a statistic that an open heart bypass procedure at the famous clinic in Cleveland now is $108,000 a person. If we start that kind of money to spend on end-stage disease, we surely are not on the right track. So let me end up by saying, yes, primary prevention, yes, early treatment, they are probably linked, and we shouldn't be afraid of saying it. We should not be forced by an organization like EFSA that you can't talk about prevention when you mean early treatment. It should be an open discussion, and doctors should be made aware that that's where their main duty lies. Thanks for being here.
Thanks.